And go ahead. The stage is yours. Nancy, would you like to go first?
All right. Thanks, Tony, for having us. My name's Nancy Beckley, and I'm retired. So I think that's kind of a fun thing to say. So when I'm retired, I'm still keeping my finger in the pond, so to speak, with the stuff that I've done most of my career. In fact, for the past 20 years, Rick, you know that the very first presentation I ever made at the private practice section was 20 years ago, and it was how to survive a Medicare audit. So I've never turned back from that. That's my particular area of expertise. It's compliance program review. So an audit really is a compliance program review. So I've known Rick a long time. We're colleagues, and Rick and I often wonder who's going to come up behind us and take over what we've been doing. So Rick, how are you doing?
I'm doing good. I'm not retired, but I'm a grandfather now, so we'll say that. And again, thanks Tony for having Nancy and I here this evening, or I think it's the evening for most of us, not even on the West Coast. We're getting towards dinner time here. Again, my name is Rick Gawenda, and again, I do the same stuff as Nancy, but I tend to focus a lot more on maybe the coding, billing, documentation aspect of outpatient therapy, and also now get to work with attorneys who maybe have clients that are PTs, OTs, SLPs, and maybe might be in some possible legal issues either with their state or with insurance companies. So try to help them out as well. But always a pleasure to do stuff here with Nancy. And we've known each other a long time, and it's always fun to do these together.
All right. So as people are joining us tonight, we're talking about the Medicare CERT program. So Rick, if you would, because truthfully, I think it's one of those things, it's kind of a hidden gem that we don't even know about in many corners of therapy. So could you tell us a little bit about the context of the CERT program, what CERT stands for, and just kind of how this all originated?
Yeah, so obviously the CERT program really is to identify improper payments that the Medicare program has made to both suppliers and providers. And I know one thing, Nancy and I are very, I guess, maybe strict on is the terminology, so suppliers and providers. So a supplier, that would be somebody in private practice in the eyes of the Medicare program. Providers would be a facility based, such as a skilled nursing facility, hospital outpatient therapy department, a rehab agency, etc. So the CERT program here looks to identify improper payments. Believe it or not, improper payments are not just always overpayments; they are underpayments. And Nancy and I are going to obviously touch on this evening about the most recent report that came out on claims that were submitted July 1 of 2019 through June 30th of 2020. And to no surprise, when we talk improper payments, the vast majority of them were considered to be overpayments to suppliers and providers rather than underpayments. So Nancy, would you like to add anything to that?
Yeah, the particular program is designed to take a look at a statistically valid, stratified random sample of providers and suppliers and DME suppliers. So Tony, you had mentioned this is the first time you've ever, gotten anything like this in the 20 some years that you've been in practice. It's entirely likely that many people that are in our Facebook groups have never received a CERT review. It's an audit to determine if your MAC paid you properly. So if the MAC didn't pay you properly, or paid you properly, so to speak, then you will get that money recouped. The MAC will come back and recoup it. It's a unique program because it's an audit that the MACs want to go really well. They want you to turn in your documentation. In fact, they will call you 3 times, email you, message you, and say you haven't turned in your documentation. So you don't have that in a regular audit, do you, Rick? You don't.
No.
You don't have that at all. So that's kind of my thoughts on it. It's a calling it an audit. It's an audit on the MACs. It's not an audit on the provider.
Yeah, and something Nancy said, it's just a random sample of claims. So the data Nancy and I are going to share with you, it's really only 50,000 claims are reviewed. And as Nancy said, that 50,000 is a combination of Part A inpatient claims, Part B claims that would include outpatient PT, OT, SLP, and DME. So what then they basically extrapolate that number, that data, based on all the claims that were submitted to kind of come up with this improper payment rate that they say would have existed during that 12-month period.
So what did we find out, Rick? You know, we both kind of posted the same day, and a bit of serendipity. Both of our brains were going the same way. And we both posted, you know, different elements of it. What are your highlights on that?
Yeah, and I think Anthony asked this question as we got started. You know, what is kind of an improper payment? And again, improper payment can be overpayment, can be an underpayment. So again, just some examples of an improper payment can include that payments to an ineligible recipient, payment for an ineligible service. You know, believe it or not, sometimes MACs may not have the quote edits turned on correctly when you do the billing. It's just an automatic thing. And maybe, for example, PT or OT, you bill iontophoresis to your Medicare contractor. We're going to say maybe they don't cover iontophoresis, or perhaps the diagnosis code you had on isn't a payable diagnosis code for ionto, but you still got paid for it. Once they realize they paid you and they should not have paid you, you know, that could be an example of you got payment for an ineligible service. You know, sometimes duplicate payments happen where providers get paid for the same service or item on the same date of service. The scary one here, payments for services not received, or payments for an incorrect amount. So, you know, what the report found is, you know, overall on claims submitted from July 1 of 19 to June 30th of 2020, they found overall there was a 6.26% improper payment rate. So basically they said, you know, 93.74% of the time, the MACs paid the claims correctly. The claims should have been paid. It was at 6.26%. You know, unfortunately, that 6.26% comes out to, I think, just about, what was it, Nancy, $25.3 billion, I believe.
Mm-hmm.
Yep. So, you know, what do we find out? I guess we probably need to maybe give a little quick overview of, you know, what are the 5 improper payment categories and what's included within each category as it applies to, say, outpatient PT, OT, SLP.
And Rick, these categories often apply categorically in the other audits by program integrity contractors in the MAC. So they use the broad categories, but then you have to drill down to what is the specific reason under the category, but they lump them into certain categories and have rules that put them into those categories.
Yep. So, you know, one of the improper payment categories is titled no documentation. Well, what's an example of no documentation is the CERT contractor requested the documentation from you. You did not send in the documentation. And as Nancy said, they may have called you 2 or 3 times. You still did not send that in. And as Nancy said, you know, other entities that are maybe doing medical record reviews, medical record audits, same thing. When they request records from you, they typically give you 45 days. 30 days plus they allow that 15 days for mail-in, 45 days to get those records in. You don't send them in, the claim gets denied under the no documentation category. The second improper payment category would be insufficient documentation. So some examples of that is maybe a physical therapist billed for 2 units of therapeutic exercise, but when the reviewer looks at that date of service, they read that documentation. In their opinion, the documentation only supports maybe 1 unit of therapeutic exercise. So technically speaking, there was insufficient documentation to support that 2nd unit of exercise. You know, another example could be an occupational therapist, you know, billed a unit of manual therapy, but there is no documentation for that date of service by the occupational therapist that manual therapy was provided. And probably this is a big one, and I'll turn this over to Nancy after I say it, a specific documentation element that is required as a condition of payment is missing. And to no surprise, the big one, I think, for PT, OT, SLP is a signed and dated either initial plan of care or updated plan of care by the physician. Either you don't have it or you did not send it in with the medical records. So Nancy, I know you see a lot of that too, I believe.
Yeah, I've been involved substantially in multi-million-dollar appeals and whatnot with OIG audits and UPIC. Those are the fraud investigator audits. Rick, I know you've recently gotten involved in some of these that require testimony. And it amazes me that, and Tony, this should be of no surprise to you, it amazes me that this key, critical, one thing you should be doing is just not understood. And, maybe Rick, you and I read the manual every night, I think, and go to sleep by it. It's kind of like our sound machine, seriously. But Medicare has made no question about what's required. And it is fairly easy to understand, but you have to have a command of it. You have to be very confident in understanding it. And so that is the thing that always amazes me, that many times you can mitigate this. This is the one thing that's mitigatable, even 2 and 3 and 4 years into the future, by getting a delayed certification. So documentation should never go into any contractor without that being reviewed and understood. And I think many times when I end up with people coming to me, it's not when they're submitting it, it's when they got, when it's all denied, is that, well, my biller said they were going to do it, or the front office person said they were going to do it, or my teenage daughter had nothing to do that summer. These are all real serious excuses. And if the people that you're charging with doing this don't have the proper instructions or didn't have access to the detailed letter, and you do get a detailed letter on every review on what to include, this is where these problems happen. So I think the plan of care certification, it all starts there.
Yep.
So
yeah, and I know on Anthony's Facebook group, obviously the big discussion here over the past, 6-7 weeks, those green envelopes are showing up, where Meridian Healthcare Solutions is doing those post-payment reviews on dates of service January 1 of 19 through December 31 of 19. And, I know right now it's going on a lot here in California, along with New York, New Jersey, Massachusetts, that northeast part of the country. And many of the clients that have retained me, one of their big deficits is they don't have a signed data plan of care. And when you think about December 31 of 19, add 2 years onto that to get that thing signed, that's December 31, 2021. You're talking to people like myself or Tony or someone else in February, March of 2022, you're past that 2-year window now for really that delayed certification, that delayed recertification. So I echo everything Nancy said. I think that's something we all have to work on and set up the right processes within our practices, within our organizations.
Yeah.
Real quick.
And Rick, Tony, and Rick, it's an urban myth that if you show that you fax 3, 4, 5, 6, 7, 8, 9 times, you press the button in your EMR that said send the fax out, that it's good. And there's some people that say, I was always told that it's 3 times, I was always told it's X. And actually, if you read in chapter 15, it basically says that you can mitigate not having it signed, and the contractor may take that into consideration. That's the CMS contractor, not other program integrity contractors. So they may take into consideration, did you have an order? Did the person sign the first plan of care? So all of a sudden you're looking through your notes and you don't have an order. Well, we're a direct access state, so we didn't get an order. Okay, so that's not going to help you mitigate it. The contractor sees that you just hit the fax button, but there's no notes in your chart. There's no notes that you communicated with the physician. There's no notes that you put in there that you talked to the physician, that the patient came back from a physician visit. And Tony, like you do those visits straight with them. And I'm sure you put it in your notes. So you are left without mitigating ability. So that is, I want to just state it again. It's an urban myth that all you need to do is refax. the certification and you're good.
I wanted to touch on two topics. Like Rick nailed it 100%. It's having the systems in place, the procedures. I know, Nancy, you're a huge fan of systems and procedures. You have to make it an infallible system. Like you have to make it where it's impossible. So one of the things that we've been moving toward and teaching is, look, you cannot submit a claim to Medicare until you have that signed plan of care back in your possession. I think the trap, and the thing that I never realized until I started teaching the zero to paid course, is therapists are getting paid. And by the fact that they're getting paid, they think that they're doing everything correctly. And it's not knowing what you don't know. So they think, well, I got paid, no problem. Then all of a sudden they get the green envelope and they get the list of 19 or 20 items that, is being requested. And they realize, I don't have this stuff, but I got paid, so I must have done it correctly. And so that's one of the main themes that I'm so appreciative of you guys coming on, is to help us realize and find the resources to say, look, it's black and white. Here it is, black letters on white background. This is what actually needs to be done. And then to Rick's point, develop the systems that make it impossible for you to make those mistakes. We all make mistakes. I make mistakes every day. The problem isn't making the mistake as much as not catching the mistake, not fixing the mistake, and not preventing the mistake from happening again in the future once you know it. So go ahead. I love what you guys are doing.
One of the things I'd like Rick to do is take us through the pathway. Rick, we saw an error rate on what's the code for PT. We'll talk about that.
Yeah.
And then let's talk about why there's differences in error rates for PT and OT. I want Rick to speculate that on a little bit. Then I'd like to follow up and talk about how this information helps the therapists that are listening, that are in our groups, and how it informs the other reviews that are going on, how this relates to the green envelope review, Tony. And I think you also got a TPE review in Ohio. So Rick, what happened in that report?
Well, if you don't mind, I'm going to finish the last couple categories real quick.
Oh, yes.
The third category would be medical necessity for improper payment. And a good example of that is the cert contractor reviewers. You sent the documentation in. However, when they read your notes, this documentation really did not support. It required the unique skills of a therapist to provide. So an example could be the cert contractor reviews a documentation submitted by a therapist, and the therapist had the Medicare beneficiary performing the same 6 to 8 exercises the past 4 to 5 treatments, and there's no documentation by the therapist or the assistant demonstrating what they were doing for the patient, maybe in terms of, verbal instruction, verbal correction, technique correction, posture correction, things like that. The fourth category is called incorrect coding. So obviously the easiest one here is you build a different CPT code than what documentation supports. So for example, you build 2 units of therapeutic activities, but the documentation actually demonstrates that it was actually therapeutic exercise was provided, and you should have billed 97110. Again, a big one I'm seeing right now because of the quote green envelopes, and also it's one of these, and I always have to use these words carefully. I don't do quote legal work, but I'm on a case right now with an attorney that has retained me for this reason about incorrect coding. The service was performed by someone other than the billing provider or supplier. This is a big one. I'm going to say it first. I'm going to turn over to Nancy. Therapists in private practice, you've got to get each individual therapist enrolled in the Medicare program. And a big misconception out there is, okay, Rick works this practice. I now hire Anthony, brand new to Medicare. We submit Anthony's application to the MAC, and while Anthony's waiting for this to be approved, Anthony's seeing Medicare patients. I'm co-signing his notes, and it's being billed under my NPI number. What you really want to do, in my opinion, is bring on Anthony, have him submit the application on PECOS. I know he teaches all of this. Make sure it gets accepted. And then once it's accepted by your MAC, that therapist can start seeing Medicare beneficiaries. You just have to hold the claims until your application is approved, because it's going to be a retrospective and an effective billing date that will go retrospectively. This is one of the cases I've been retained on by attorneys, because the OIG, this is what true case, this OT had other OTs doing the therapy, was all being billed under their own NPI number. And it caused severe red flags. And that's a big issue, not only with Medicare, but with private commercial payers as well. Nancy?
Mhm. Yeah, and actually, this is finding its way into the mainstream. Previously, it was just let's take this claim date, and that's how they pick stuff, a claim date, and review the claim. And then, of course, to support the claim, you need a certified plan of care. Generally speaking, any progress reports that appeared before the date of the claim. And if it's a post-payment review, a discharge note, which is the final required progress report. So that actually has been stuff that CMS has borrowed from the investigative authorities. And I call that the OIG under investigations, and various assistant United States attorneys offices that are getting tips or taking whistleblower claims. And there's been some huge ones in therapy at the end of 2021, just absolutely huge, that are very informative, where they're taking a look at this. One of the things you may recall, there's a large, and I won't mention the name here, but it's publicly available. It was by the United States Attorney's Office in South Carolina, who's very active on therapy reviews, by the way, when those whistleblower claims came in. And it was a large company under private equity. And if you read the appendix goes through the schedule and shows about how things couldn't be done. You fast forward, meaning because there was not sufficient time for what they were billing, not that they were double booking, but what they were billing was not consistent with the way that it should have been billed. So fast forward a few years, and I've been involved in a couple of whistleblower cases wherein, the allegation, when they get the schedule and they take a look at your commercial schedule and your Medicare schedule, is what they're trying to take a look at is who performed the service, who was on the schedule, were the people that were on the schedule in the office that day signing the notes. And I think, Rick, that's one of the criminal cases that you're on, where somebody's not there. And many times you read these things and they say, in fact, the person was out of the country or on vacation in the Bahamas or whatever. And that is something now that CMS is bringing back in a more subtle sort of way by asking for schedules. So they're seeing that. Now, you don't see this in the CERT audit. In the CERT audit, we're just taking a look at, was this claim paid properly, as Rick noted. So that's kind of the pathway there. But I want to come back to, we promised everybody we would say what the findings were, Rick, and I know you're excited to talk about it.
Yep.
So
and the
what are those bad boys?
All right. Well, the fifth category is just called other, and that would be like a duplicate payment or non-covered or unallowable services. So improper, let's go PT first. So the improper, now remember, overall, the improper payment rate was 6.26% overall. The improper payment rate for physical therapists in private practice, 15.5, so 15.5%. The projected improper payment then is just over $423 million. To no one's surprise, it's not to my surprise, and I'm thinking probably not Tony or Nancy's either, 89.5% of the improper payments was because of insufficient documentation. 2.4%, no documentation. 2% incorrect coding, and then 6% fell into the other category. So insufficient documentation, 89.5% of it for PTs and private practices. For OT, the improper payment rate was 9.8%. Projected improper payment was just over $43 million. So for PT was just over 423 million. Obviously PT much bigger than OT. So OT just over $43 million in improper payment. Number one reason, same as PT, insufficient documentation was 86%. Medical necessity was 2.7%, and the other category was 11.3%. Your top 10 states, well, I mean, my opinion, no surprise. California, number 1, Texas, number 2, Florida, number 3. Tony, you made number 4. Ohio, number 4. Pennsylvania, 5. New York, 6. New Jersey, 7. Georgia, 8. Tennessee, 9. And Maryland, number 10.
Real quick of note, Nancy mentioned this before we started. These numbers are coming from 2019, which means pre-pandemic. So it's not even like there's the excuse to say, well, you know, clinics were shut down and we couldn't get access to medical records or anything like that. This really was before all of that. Am I right?
Well, it was claims submitted July 1 of 19 through June 30th of 2020.
Okay.
So there could be a couple months of pandemic claims.
Sure.
Yeah, there'd be a few months of the pandemic there. But, you know, again, I think that big one is still just that insufficient, you know, documentation, which I think is a big one. It always has been. You know, I think we see that a lot, whether it be Noridian doing those post-payment audits or any other audits that, you know, go on with your Max. I think that's just always a big one.
Yeah, I know, Rick, you have some great courses on documentation. I know Nancy has a video on her YouTube channel talking about Medicare required documentation. I think the information is certainly out there, but, you know, how do you both see the impact of electronic medical record on all of this? Because I'm still in the Stone Age. I'm still carving, you know, blocks of stone with pen and paper. But that being said, I mean, do you think the EMRs are moving us in the right direction? Helpful, hurtful? What are your opinions on that?
Yeah, that's a great question. And I've said this all along about EMR systems. I think EMR systems are very good in that they can help you track certain things. You know, for example, they can, you know, track that 10th visit progress report when it's required. You know, if you do the dates right, it can tell you when you need to do an updated plan of care, or when your initial plan of care is going to expire. You know, for those insurances that require prior auth and you get so many visits, it can do all of that. Yes, an EMR system can make you have to put something in each one of these boxes before you can sign off on it. However, in each one of these boxes, can I just write the sun came up today? And then that gets me out of that box where technically then I can go sign off on the note. So I think EMRs are good that they can make you do required fields. They still can't make you write what you have to write. You know, what I'd love to see with that insufficient documentation for both PT and OT, because one of the categories in that is missing plan of care. What we don't get that breakdown of, okay, out of that 89.5% insufficient documentation, what percent was due to, say, missing an element like a plan of care? What was this? What was that? It doesn't, you know, go into that kind of detail. So it's just left for us to try to guess and assume. So I think what Nancy, what you do, apparently your dog does not want to listen to me talk anymore. Okay. No one wants to listen to me talk on complaint. My wife left me. The dog wants to leave me, I tell you.
Well, you know, Rick, I did a number of years ago an investigation that I was engaged by a client to do, because a traveling therapist, you know, a rental therapist that comes in, so to speak, did exactly that in the EMR. They didn't want to write the notes, so they hit the space bar and type one, you know, like, you know, ... And it was sufficient enough in that particular EMR. Long gone when one of those charts pops up on a routine audit. Now, remember, and this brings up a good point, Tony, about in our groups where people talk about hiring 1099s. In 2 years, where will your 1099s be? And how can they sign notes that they weren't there to sign? How can they finish documentation that they didn't finish? And by the way, how can they write the cover letter that you should be sending in? And if the money's recouped because their notes were so bad, but you've paid them, you'll never find them. Like you said, it's you know, with your policy on grabbing patients for their money. But I'm going to come back to my views on EMRs, and I'm of the generation of the CMS 700, 701, and yes, there was a
Me too.
702, and so was Rick. So to that end, it informs you of essentially CMS never required it. They stopped like a milliliter of not requiring it, but it was a CMS form. The industry had input on it at the particular time. It's great to tell you how to put things in boxes and categories. So now you come fast forward and we have EMRs, like Rick said, where you put in a box, you have drop-down menus. Therapists sometimes forget to write a note. And that's what I see when I'm proofing and reviewing and helping somebody submit their package for whether it's an audit or an investigation, or the TPE audit, which, Rick, as you know, they will come back, and if you ask them what was this there, they'll tell you, because you have the education portion, so you can find it out there. So I'm kind of the viewpoint, having my nose in thousands and thousands of medical records, because I do compliance reviews, and I don't do checklist audit. I look for a lot of other things in the documentation thing, that the most insufficient part, my opinion, where therapists fail to engage in their EMR, is a solid evaluation. That the most insufficient part, my opinion, where
Wow.
therapists
Little feedback
fail
there.
to engage in their EMR.
So let me
is a
ask you,
solid
talking about that.
insufficient part.
Can you hear me okay? So let me ask you, talking about that.
Are we good?
We're good. I'm good. Are you good?
Okay, I'm not sure. Maybe there was something on my end.
I was hearing sound or something.
Talking about documentation, talking about the evaluation, the plan of care, following, you specifically said you're not doing checklists, that you get far more detailed. While I have the two of you here, two big questions. One, I know there are state guidelines that require maintaining documentation for a certain number of years. There's also the third-party payer guideline. Could you shed some light, maybe specific at least to Medicare Part B? What are the guidelines? How long does documentation need to be maintained before it's destroyed? And then, of course, there's people that have asked about the redundancy. Do we need 2 copies of the documentation in case of a hazardous event or anything like that? I'd love to hear that.
Well, first of all, you look to your state medical records to see if there's any item there, and you're always going to follow the strictest. So you're
Right.
going to look to your state if they have guidelines for medical record retention. For Civil False Claims Act, the tail 6 years. For the Criminal False Claims Act, it's 10 years that you want to keep documentation. And by the way, Medicare Advantage plans are required, and it would be in your contract, because it's in their contract with CMS for 10 years. So that might be something that people are learning today about that. In each state, when you have minors, generally the state has a different requirement that speaks to the age of majority and how many years after the age of majority that those medical records must be maintained. Does that help, Tony?
That does. Thank you so much. And the other question that comes up, that's been coming up quite a bit, is talking about good old copy paste. Since we are an electronic world, is there any guidance when we're going, under review or an audit or anything like that? The components that, are carried forward from previous documentation, from other plans of care, from notes, where are the guidelines for what can be copied forward? What needs to be original context? Obviously, there's stuff unique to the patient that must be original. But what about when we're dealing with post-surgical protocols, and maybe the plan of care has components that are similar across multiple cases? I'd love to hear anything about that.
Yeah, I think one thing that's very confusing for an auditor perspective is you've got, say, an episode of care that's 12, 13, 14 visits. Now, my opinion is you go from visit 1 to 2 to 3 to 4 to 5. Do I think subjective comments should be the same? No, I think that should be different. I think assessment would be different. When I'm reviewing claims, and this is more when I'm doing record reviews, maybe been retained by attorneys to look at documentation or insurance companies. I'll be honest, in a daily note, I don't really want to see the goals carried forward in every daily note. I don't want to see the entire plan of care carried forward in every daily note. And it's the same note after note after note after note. Now, if you're going to update a goal, modify, change it, you're going to do something to plan of care, that's when I think you should put it. But I think it's very confusing for a reviewer and auditor when everything carries forward note after note after note. I'm okay with exercises carrying forward as long as then the therapist and assistant, they're changing sets, repetitions, resistance. There's maybe documentation of what they're still doing for the patient, hence why it's still skilled therapy. And the patient's not doing this by themselves, maybe as a home exercise program.
One of the exercises that I like to do, and I started doing this when I was being called in. It was back in the day when there weren't many private practices, because private practices only had a $900 cap before the Balanced Budget Act. Most private practices at the time didn't engage in Medicare. That was left to rehab agencies for the most part prior to 1997. So during my early consulting years, many rehab agencies that sort of failed their max medical record review, because they had active medical record reviews for rehab agencies of a certain percentage for a certain length of time after you became a rehab agency. So if you kind of flunked too many, they required you to have somebody come in and do a training. And it was always kind of fun because I took a tip that I learned from First Coast in Florida when I used to go to their summer training sessions that they would have for providers there. It was called MetaFest. It was held at Church Street Station in Orlando. And they passed out notes that were redacted. And then you had to look at the notes. And so a good exercise is print out 10 daily notes and look at 10 daily notes, go down the table and write your progress report. And if therapists could write a progress report that was based on 10 daily notes by looking at the notes, the progress reports would improve 1,000,000%, in my opinion. Because many times therapists write a progress report that's not based on what they did during the previous 10 visits, because it's hard to click through 10 retroactive notes in your EMR. So that's kind of, one of the areas that I'm always taking a look at with repetitiveness in the documents. And that's what leads oftentimes for therapists to replicate another 4 weeks on their plan of care for no reason. They prescribe a plan of care, as only a therapist can do. And they say it's going to take so many weeks based on their clinical experience and judgment. And they get to the end of those so many weeks and they ask for 4 more weeks. And I often think it's because they didn't read their own notes. So, so that's kind of one of the things that's a mystery. So I always tell people from my trainings that I did, 20 years ago, 23, 24 years ago, was print out those notes. Let's look at the notes. Let's line them up and let's go from note to note to note and what changed. So
now I would love to hold my feet to the fire, and I want to do it just briefly. And then I want to move to Nancy, how we can use the information that Rick and both of you are sharing to improve our businesses. But one of the frameworks that I've really just been fond of forever, and the way I explain it, and please criticize it, critique it, do what you can to help the people that are listening. We have almost 50 people on here live, at least that I can see. I look at my plan of care and specifically the goals, and we're going to talk long-term goals, functional goals, while I still use impairment goals. But I look at that as a table of content. So if I was going to open up a book, War and Peace, and I'm looking at the table of contents and the chapter headings and what's going on, each of my goals in my plan of care is associated with a specific treatment throughout my plan of care. So when I'm looking at, treatment number 2, referencing goal number 1, treatment number 3, referencing goal number 2, I've got a very clear sequential, okay, this is very simple to understand. Like Rick said, it's not confusing. I can go back and forth and very easily see it. Obviously, we're not going to hit every goal on every treatment. So then once I run through maybe 8 of my goals, I can revisit some of the goals that weren't initially met. When I'm ready for my 10th visit progress report, or if I'm going to do it sooner, I've got everything very clearly outlined. And so I try to use that framework. Now, within that framework, what I find, and I kind of got persecuted a little bit for this because I made the statement, you really shouldn't use your brain. I said it in some way, all that much when you're documenting. And it was interpreted as you shouldn't be thinking critically and you shouldn't use, your clinical mind. That's not what I'm saying. What I'm saying is the system for documentation should be so automatic and so clearly laid out that everything is right there. You're simply putting the information into the skeleton, the format that the reviewer or the third-party payer or the physician can easily follow. And you're not having to think of every single day like it's a brand new day and what am I doing and what do I need to, record and all of that. That should be established within the plan. And then everything subsequent to that is plug and play. Yes, you're assessing your patient and you're documenting, changes to the treatment and all of that. But it shouldn't take the mental energy every day to approach it as if you're reinventing the wheel. So any thoughts, any feedback on a simple framework like a table of contents, chapters that correspond to the daily notes?
No, I mean, I agree. When I'm doing my teaching, whether it's a webinar or live in person on the country, we talk about plan of care. That's obviously a common question I get all the time is, do I have to document every daily note why I'm doing what I'm doing? And the answer is no. And it should really be in your initial plan of care. And, I know a lot of times people will just, do the classic patient will be seen 2 times a week for 6 weeks. Treatment may consist of Therax, manual therapy, ultrasound, etc. And I say, well, why not there say therapeutic exercise to increase shoulder range of motion and strength, manual therapy to do this, self-care for this, therapeutic activities for this. And then at least the reviewer will understand, well, here's why Tony's doing Therax. Here's why Rick's doing manual therapy. Now, if the reason for why you're doing manual therapy changes on visit 5, visit 6, I think that's where you do that. And I think that's important because, my last comment on that report is, this report also lists the top 20 CPT codes that have been, quote, overpaid. And good old CPT code 97110, therapeutic exercise, made the top 20. It had an overpayment rate of 17.8%, which is estimated to result in almost $200 million in projected overpayments. And do I think a lot of that can be because maybe we did not set it up right in the plan of care, number one. Number two, the good old carry forward feature where you did the same 5, 6, 7, 8, 9 exercises 4, 5, 6, 7, 8, 9 days in a row, and you didn't document maybe why the patient was still doing in therapy, why it still required your skills, what were you doing for the patient? But yeah, I agree. Try to minimize the writing, use your brain to a point, but I do agree it should be, here's what I did. Here's what the patient told me. Here's what I did for the patient. Here's what the patient did. Here's what we're going to do the next time they come in. If you're thinking for 6, 7, 8 minutes how to write the note, I don't know, maybe you're still hungover from the night before or just too many pages. I don't know.
Well, I'm big on, I want to go back to the eval codes, the new eval codes that we got for PT and OT.
Yeah.
And, when they premiered, everybody was sort of late to the game. They approved them. We had literally, remember, Rick, we were down at the PPS meeting and we were waiting for the final rule to come out, and you and the payer policy committee, you and Mary DeLong were doing that training presentation. And it would seem like the big rush was to tell everybody what the difference between the 3 levels were and to give the numbers, and all of the tools that were put out suggested or gave the wrong impression that you just needed to meet a few of the criteria on each line and pick it. If you go strictly back into, and Rick's done some excellent training on this, go back into the International Classification of Function and really get into what those codes are about, you'll have a plan of care that you can not think about, Tony. And that's exactly what I thought about. If you line your evaluation up, and the EMRs kind of really aren't drilled down to that level. They asked some probative questions regarding the categories, but in order to get to the categories, you have to go into the international classification of function. Rick's got some good stuff on that, has done some excellent training on that. Time to revisit that, Rick, and maybe do another thing on that, because I think a therapist that does a good eval is never going to have problem with medical necessity for their plan of care.
I agree. It all starts there. If you can't get the eval right, if you can't show here's why the patient needs me, here's where they were before, here's where they're at now, here's their functional deficits, here's their functional goals. If you can't set that up, I've said it many times, you're done the next 8, 9, 10 visits. You're just done. You have nothing to go on.
And I hope this is not news to people, but the OT codes are different.
Yeah.
So, and the framework for OT, now we're on framework number 4. I've actually done some longtime clients that I do annual compliance training for. I'm no longer doing it, but the first year that came out, I was with about 50 therapists and big orthopedic surgery practice and high-end therapists, obviously, when you're working, and good chunk of them were OTs. Not a one of them, all seasoned CHT certified, not a one of them knew what the framework was. Because they were seeing themselves as a CHT. They didn't care if they were a PT or an OT, they were a CHT. And so I was so shocked doing the training on the new codes as part of the annual compliance training that I had to actually bring to their attention that they had all graduated and got through OT school before all the framework stuff was out. But I really want to bring that importance out too, that many times if you have OTs in your practice, you have to be using an EMR that's going to be able to allow the therapist to differentiate, because it's a very, very different tool set that's being used to describe and inform what that plan of care is.
Yep.
So I want to be mindful and respectful of both of your time. We have about 10 minutes left. Were there any other topics, information that you thought would be worth sharing that we hadn't gotten a chance to? Nancy, I didn't know if we covered all of the topics that you wanted to touch on.
Well, one of the things that I would like to say, and I don't know if it's a question, but it's probably a heartfelt feeling, that many people are jumping into Medicare as an independent practitioner for a whole lot of reasons. Maybe they left the SNF industry. Maybe they needed, they left another job and they want to just self-actualize and do what they're doing. When you're jumping into Medicare, you've heard me say in for a penny, in for a pound. Don't jump in until you have some resources that are put in place. And none of the resources are horribly impossible for somebody to pull together on themselves. Some of it is just, what time do I want to pay to get a specific resource? One of the key resources that I think, given today's age and the Office of Civil Rights Enforcement, is to make sure that your HIPAA is up to date. I see that as a huge area of concern of mine. So that's kind of one area. If you're in and you're billing Medicare, if they're taking your course, Tony, they've got to have certain things in place. And then the other thing, from a compliance perspective, is understanding those nuances. Oh, I'm just going to take Medicare and then cash for everything else. All of a sudden, people fall in the trap. Well, it was really a Medicare Advantage plan. Well, they had Medicaid, so they were a QMB, and we see that. We see all of a sudden things get tipped. I've always kind of felt that if people could get a solid cash practice going, once your income is there, it's easy to kind of pivot a bit and take Medicare. And once you get into that Medicare thing and you're trying to attract, Tony, you always say it, all of a sudden you're working on a whole lot of stuff. So I encourage people to, when you dip your toe in the water and become, enrolled in Medicare and want to work with these beneficiaries, there's a whole lot of work to do that you can do before you enroll. It's hard once you're desperate and you're trying to pay yourself and get your money coming in, and you're getting error messages like we're seeing people not getting their claims paid, or CMS messes up claims. So that's kind of my thing that I say to people. Right now I'm keeping my finger in the compliance function, which is taking a look a little bit differently at documentation and compliance. And I'm, the applicability being the laws and that type of stuff. So I have a unique bend to it, and I'll defer now over to Rick that for years and years and years, I always referred people when Rick was on the traveling circuit. If Rick's coming to town, that's what you need to do. Even my clients under a compliance program, because that was the hardcore training on documentation, coding, and billing. Compliance training on that deals with risk areas. So my training on documentation strictly deals with compliance risk and case studies. So, but thanks, Tony, for having Rick and I on. And I know Rick wants to add a few tidbits too.
Yeah, I mean, I would probably echo what Nancy said, and also just toss in Medicare Advantage. I think the biggest mistake people make is people think Medicare Advantage, Medicare are the same, and they do have different rules, regulations. I know Tony has seen me posted on his Facebook page, and what I'm going to say next, I put on other Facebook pages and Twitter. You can't learn everything off Facebook. You can't learn everything off Twitter. I don't care if you pay me. I don't care if you pay Nancy. I don't care if you pay Tony. I don't care if you Google. I agree with Nancy. Learn this stuff maybe before going in as much as you can, because I will also admit, you don't know what you don't know until you realize you don't know it. I know that's a bunch of don't knows, but there are, I think, some things you can learn ahead of time. Also, I think you should belong to your professional associations. APTA, AOTA, ASHA. Use them. That's your dollars. So, it's funny, I get a lot of SLPs that email me questions, and I'll go, did you contact ASHA? No. Well, I know you're a member because you're an SLP. Contact ASHA and contact your state therapy association. Take advantage of your membership. Tony's got some great stuff to do. Nancy still does the compliance stuff. There's others that, I don't want to put out a bunch of names because then I'm going to leave somebody out. So I won't do that. But, there are others that provide services, and, just search it out. And I don't care if no one uses me. If you want to go use somebody else, that's fine. I just don't want to get a call one day from an attorney that's representing you, and we're on the deep end going the other way. It's better to pay $300, $400, $500 now than thousands of dollars in sleepless nights later. And I'm not saying that to scare you, but it does happen. Unfortunately, I'm retained by the attorneys, and it does happen.
I totally agree, and neither of these two wonderful human beings will say it, but Nancy has an amazing website. I think I've purchased everything that's applicable to outpatient private practice from Nancy's website. I'll post a link to her website down below. And of course, I've been a gold member of Rick's membership for multiple years now, and his courses and content that he puts out there. I mean, the reality is, as much as I love what I do and I'm passionate about what I do, and I view what I do as a way for me to give back to the profession, I can never teach a clinician how to be a better clinician. Most of you guys are probably better than me, but if I could give back from my 22 years of experience and multiple mistakes, that's what I want to do. But I would absolutely check out the resources that both Rick and Nancy have shared. I'll put them down in the video description. The replay for this video will be available to everybody publicly. And guys, don't get off when I stop the live stream, but I just want to say once again, you both are pillars in the community of PTOT SLP. You're so well respected. I don't know that you could ever imagine the reach that you have into the community and how many lives you've changed through the clinicians that you've helped, and then the patients of the clinicians. It's just unreasonable. So thank you both for being here and giving us your time tonight.
No, thank you for having us. Thanks, Thank you for the kind words.
Absolutely. Tony. Stay right where you are.
Okay.